Hello everybody, this is our stroke series, and in this we are going to discuss about general management and the complication of the stroke. So the use of comprehensive specialized care that incorporates rehabilitation is recommended, and the use of standard stroke care order set is recommended to improve general management. This is the class of recommendation 1. So regarding the head position, the benefit of flat head positioning early after hospitalization for the stroke is uncertain. This is class of recommendation of 2B. Now regarding supplemental oxygenation, airway support and the ventilatory assistance are recommended for the treatment of patients with acute stroke who have decreased consciousness or who have bulbar dysfunction that cause compromise of the airway. This has class of recommendation 1, and the supplemental oxygen should be provided to maintain oxygen saturation more than 90. Supplemental oxygenation is not recommended in non-hypoxic patient hospitalized with the acute ischemic stroke. This has a class of recommendation 3. Now, regarding the control of blood pressure, hypotension and hypovolemia should be corrected to maintain the systemic perfusion level necessary to support organ function. Class of recommendation 1. In patient with acute ischemic stroke, early treatment of hypertension is indicated when required by comorbid conditions. For example, concomitant acute coronary event, acute heart failure, acute aortic dissection, post-fibrinolysis, ICH, preeclampsia, and eclampsia. This has class of recommendation 1 in patient with the blood pressure more than 220 by 120 who did not receive IV alteplase or mechanical thrombectomy or have no comorbid condition requiring urgent antihypertensive therapy. The benefit of initiating and reinitiating treatment of antihypertensive within first 48 to 72 hours is uncertain and it might be reasonable to lower blood pressure by 15% during the first 24 hours after onset of stroke. This has class of recommendation 2B. In patient with the blood pressure less than 220 by 120 mmHg who did not receive IV alteplase, mechanical thrombectomy, and do not have comorbid condition requiring urgent antihypertensive therapy, initiating or reinitiating treatment of hypertensive within first 48 to 72 hours after acute ischemic stroke is not effective to prevent death or dependence. This has class of recommendation 3. Regarding temperature management, source of hyperthermia should be identified and treated. So antipyretic medication should be administered to lower temperature in hyperthermic patient with the stroke. This has class of recommendation 1. In patient with acute ischemic stroke, the benefit of treatment with induced hypothermia is uncertain. This has class of recommendation 2B. Hypoglycemia, that is blood sugar less than 60 mmHg, should be treated with acute ischemic stroke. Class of recommendation 1. And evidence indicated that persistent in-hospital hyperglycemia during first 24 hours is associated with worse outcome than the normal glycemia. And thus, it is reasonable to treat hyperglycemia to achieve blood glucose level in the range of 140 to 180. This has a class of recommendation 2A. Now regarding dysphagia, dysphagia screening before the patient begin eat, drinking or receiving oral medication is effective to identify patient at increased risk for the aspiration. This has class of recommendation 1. An endoscopic evaluation is reasonable for those patients suspected of aspiration to verify the presence and the absence of aspiration and to determine the physiological reason for dysphagia to guide the treatment plan. Class of recommendation 2A. It is reasonable for dysphagia screening to be performed by speech language pathologist or other trained healthcare provider. Uh, Class of recommendation 2A. It is not well established which instrument to choose for evaluation of swallowing with sensory testing, but the choice may be based on instrument availability and consideration. Implementing oral hygiene protocol to reduce the risk of pneumonia after stroke may be reasonable. Now, regarding nutrition, enteral diet should be started within 7 days of admission after acute stroke. For patient with dysphagia, it is reasonable to initiate use of nasogastric tube for feeding in early phase of stroke, starting within the first 7 days, and the place percutaneous gastrotomy tube in patient with longer anticipated persistent inability to swallow safely, that is more than 2 to 3 weeks. Class of recommendation 2A. Nutritional supplements are reasonable to consider for patients who are malnourished or at risk of malnutrition. Class of recommendation 2A. Now regarding deep vein thrombosis, in immobile stroke patient without contraindication, intermittent pneumatic compression in addition to routine care is recommended over routine care to reduce the risk of deep vein thrombosis. Now, deep vein thrombus prophylaxis, the benefit of prophylactic dose subcutaneous heparin, that is unfractionated weight heparin, low molecular weight heparin in patient with acute ischemic stroke is not well established. The class of recommendation to be when prophylactic anticoagulation is used, the benefit of prophylactic dose lower molecular weight heparin over prophylactic dose unfractionated weight heparin is uncertain. This has a class of recommendation to be in ischemic stroke, elastic compression stoking should not be used. Now, regarding depression screening, administration of structured depression inventory is recommended to routinely screen post-stroke depression. Class of recommendation 1, and the patient diagnosed with the post-stroke depression should be treated with antidepressant in the absence of contraindication and closely monitored to verify effectiveness. This has a class of recommendation 1. Now, others, during hospitalization and in a patient rehabilitation, regular skin assessment and recommended with the objective scale of risk, such as Braden scale. This has class of recommendation 1. It is recommended to minimize or eliminate skin friction, to minimize skin pressure, and to provide appropriate support surface to avoid excessive moisture and to maintain adequate nutrition, hydration to prevent skin breakdown, regular turnings, good skin hygiene, and use of specialized mattresses, wheelchair cushion, and seating are recommended until mobility returns. It is reasonable for patient and the families with the stroke to be directed to palliative care resources as appropriate. Routine use of prophylactic antibiotic has not shown to be beneficial. Now, the routine placement of indwelling bladder catheter should not be performed because of the associated risk of catheter-associated urinary tract infection. It is recommended that early rehabilitation for hospitalized stroke patients be provided in the environment with organized and interprofessional stroke care. Class of recommendation 1. It is recommended that stroke survivor receive rehabilitation at an intensity commensurate with anticipated benefit and tolerance. It is recommended that all individuals with the stroke be provided a formal assessment of their activities of daily living and instrumental activities of daily living, communication ability, functional mobility before discharge from acute care hospitalization, and the finding be incorporated into care, transition, and discharge planning process. A functional assessment by clinician with the expertise in rehabilitation is recommended for patients with acute stroke with residual functional deficit. The effectiveness of fluoxetine and other selective serotonin reuptake inhibitor to enhance motor recovery is not established. High dose, very early mobilization within first 24 hours of stroke onset should not be performed because it can reduce the odds of favorable outcome at 3 months. It has class of recommendation 3. Now, the treatment of acute complication like brain swelling, patient with large territorial cerebral and the cerebellar infarction, they are at high risk of developing brain swelling and herniation. Discussion of the care option and possible outcome should take place quickly with patient and family and next of kin. Medical professional and caregiver should ascertain and include patient-centered preference in shared decision making, especially during prognosis formation and when considering intervention and limitation in care. Measure to lessen the risk of swelling, close monitoring of the patient, and signs of neurological worsening during first day after stroke is recommended. Early transfer of patient at risk of malignant brain swelling to institution with appropriate neurosurgical expertise should be considered. Both of these treatment carries the class of recommendation 1. Now, the medical management use of osmotic therapy for patient with clinical deterioration from brain swelling is associated with cerebral infarction is reasonable. Use of moderate Hyperventilation, that is PCO2 target of 30 to 34, is reasonable treatment for patient with acute neurological decline from brain swelling as a bridge to more definitive therapy. Hypothermia or barbiturate in setting of ischemic cerebellar and cerebellar swelling is not recommended. Because of the lack of evidence of efficacy and the potential to increase risk of infectious complication, corticosteroid should not be administered for treatment of brain swelling complicating ischemic stroke. It has a class of recommendation of 3 and level of evidence A. Now regarding surgical management and supratentorial herniation. Although the optimal trigger for decompressive craniotomy is unknown, it is reasonable to use decrease in level of consciousness attributed to the brain swelling as selection criteria. In patients of less than 60 years of age who deteriorate neurologically within 48 hours from brain swelling associated with unilateral MC infarction despite medical therapy, decompressive craniotomy with dural expansion is reasonable. And both of these statements carries the class of recommendation of 2A. In patients more than 60 years of age who deteriorate neurologically within 48 hours from brain swelling associated with unilateral MC infarction despite medical therapy, decompressive craniotomy with dural expansion is considered. So it has a class of recommendation 2. Now surgical management and cerebellar infarction. Ventriculostomy is recommended in the treatment of obstructive hydrocephalus after cerebellar infarction. Concomitant or subsequent decompressive craniotomy may or may not be necessary on the basis of factors such as size of infarction, neurological condition, degree of brainstem compression, and effectiveness of medical management. Class of recommendation 1. Decompressive suboccipital craniotomy with dural expansion should be performed in patients with cerebellar infarction causing neurological deterioration from brainstem compression despite maximal medical therapy. When deemed safe and indicated, obstructive hydrocephalus should be treated concurrently with the ventriculostomy. When considering decompressive suboccipital craniotomy for cerebellar infarction, it may be reasonable to inform family member that outcome after cerebellar infarct can be good after surgery. The class of recommendation 2. Recurrent seizure after stroke should be treated in a manner similar when they occurred with other neurological condition, and anti-seizure drug should be selected on the basis of specific patient character. This statement has class of recommendation 1. Prophylactic use of anti-seizure drug is not recommended. This statement has class of recommendation 3. Thank you guys.